syncope. The reason is to know the definition. First thing is syncope is a symptom, it is not a diagnosis. It can be due to multiple causes, multiple mechanisms, but the self-limited loss of consciousness and postural tone. It is a self-limited in the sense it occurs spontaneously and the patient recovers spontaneously. What I showed where we gave a shock and bring him back is aborted sudden death. Had we waited few more minutes, that person would have died. So, syncope to define, not all unconsciousness, not all CPR given, they cannot be grouped under a term called syncope. Syncope is where the unconsciousness is rapid, sudden onset, and from which patient recovers spontaneously. He should recover spontaneously without any electrical or chemical thing. It is not like we give amiodarone push or a xylocard push or giving a cardiac defibrillation or a cardioversion or whatever you do. So, the recovery should be usually complete without any sequelae and does not require any medical or surgical intervention. This definition should be borne in mind because many times people think a sudden cardiac arrest is equal to syncope. No, sudden cardiac arrest is the worst form where the patient is not going to recover spontaneously unless we go and intervene. The underlying mechanism is, as I said initially, a transient global cerebral hypoperfusion. That's all. So, it is a central problem. It is a neurological problem where the heart has failed to pump blood to the brain. And brain is a funny organ where it does not tolerate ischemia for more than several seconds, to make it simple. 10 to 20 seconds patients start developing symptoms. Within less than 30 seconds they lose consciousness. So, it is a transient global cerebral hypoperfusion from which patient recovers spontaneously, luckily, but the luck not always prevail. And classification, how do we classify this type of transient loss of consciousness? Having said there can be syncope or not syncope. Very simple. When there is a real or apparent total loss of consciousness, there are many other disorders mimicking syncope with loss of consciousness like seizure disorder or concussion or pseudo syncope. But syncope, as the term I said, as a transient one, usually due to one of these four groups: neurally mediated reflux syndromes, orthostatic hypotension. These two are commonest variety. These two are the commonest variety. Next comes to arrhythmic or structural cardiovascular diseases. They can work together, one can precipitate the other one. But these are the common ones, these are the uncommon ones, but dangerous ones. So, underlying causes you see orthostatic or neurally mediated, it can be usually, it can be drug induced, it can be autonomic dysfunction, and neurally mediated vasovagal syncope or carotid sinus sensitivity and situational syncope. We see even post defecation, post micturition, post cough and post laugh also, as Vasu showed. And then comes the cardiac arrhythmia where it can be a brady or tachyarrhythmia or a long QT syndrome. We just give few examples, we can go to the detail when there is a discussion. And structural disease like ischemic heart disease, valvular heart disease, myocardial pathologies, pulmonary pathologies, aortic disease, myxoma, tamponade, anything. So, any major structural heart disease can produce syncope or arrhythmic thing. These are the dangerous one where the syncope is a warning sign where we have to go in and do something to save the patient life, because the next episode may not be syncope, rather a sudden death. These are more common, debilitating, disturbing to the patient, affecting his morale, confidence, everything, but rarely they kill the patient. To understand this, what happens, as I said initially, how we interact with the neurologist, just think of algebra of the blood pressure. BP is nothing but the product of cardiac output and systemic resistance, number one. Cardiac output is nothing but the product of heart rate and stroke volume. So, very clear in this, BP will be decided by heart rate, stroke volume and systemic vascular resistance. You can understand the heart does not contract very well, the heart does not beat very well, or the contractility decreases, or as intense vasodilatation. That is all. All these features going to affect the blood pressure. So, it can be a bradyarrhythmia, extreme bradyarrhythmia or extreme tachyarrhythmia one side, or very poorly contracting heart or vigorously contracting heart one extent, or extreme vasodilatation or extreme rise in blood pressure, extreme rise in resistance. All these things going to produce cerebral hypoperfusion. So, it is very easy from this point to understand what are the cause of cardiac syncope. So, anything that is going to affect the myocardium or the myocardial beating, that is the heart rhythm, or anything that is going to affect the peripheral vasodilatation. That is all. How to go in further? Coming to orthostatic hypotension. As I said, there is a sudden drop in blood pressure more than 20 millimeter in systolic or 10 millimeter diastolic when the patient stands up. This is the commonest scenario we come across mostly in the elderly people or people who are with drugs or neurogenic problem. Neurogenic problem I am not going to elaborate, Vasu is there. primary and secondary autonomic failure. So, any of these conditions can make the patient to feel dizzy and lose consciousness when he takes a sudden upright posture due to fall in pressure leading to cerebral hypoperfusion. And as I said, it is a definition we have made, and these patients many times we see a supine hypertension. Why I said this point is, when a person comes with syncope, examining the supine posture and the BP is normal or high, that doesn't preclude a hypotension when he stands up. So, check the blood pressure in both the arms, both lying supine posture and in standing posture, and look for the vulnerable group like elderly people who have a decreased baroreceptor sensitivity, low cerebral blood flow and renal sodium wasting. These are all common problems in elderly people, making them vulnerable for falls, not only falls but syncope also, and peripheral sympathetic tone impairment due to drugs or diabetes. As I said, next one is neurally mediated syncope or reflex syncope, where it's one of the most common cause called vasovagal, situational or cortical syncope. Common things we come across in young children also. It can happen even at a very young age, between 10 to 15, or elderly group above the age of 45 or 50. Point is, we usually come across the prayer or prolonged standing, public speaking, sudden fall. Results from sudden reflex mediated hypotension under bradycardia triggered by various receptors either in the carotid artery or urinary bladder, esophagus, respiratory tract, or even the heart. But what is important to understand is, as I say, is a reflex mediator. What do you mean by that? Very simple. When there is a stress, when there is a stretch, when you are supposed to stand up, all of us are standing up. When we suddenly stand up or prolonged standing in a queue, we don't lose consciousness. The body adjusts in such a way for the effect of gravity on the circulating blood volume. The blood tends to pool in the lower segment of the body, but the associated vasoconstriction, adjustment of the sympathetic tone, rise in peripheral resistance, increased cardiac contractility, they maintain the cardiac output, particularly cerebral perfusion. This fundamental thing, when this reflex, if it is not proper, so a reflex mediated syncope, I would like to define as inappropriate reflex mediated syncope. Inappropriate response by the neural system or a cardiac system for a need, for a demand, leads to cerebral hypoperfusion, causes syncope. This is what happens. How it happens? You can see, due to various afferent receptors from various parts of the body, from blood vessels to bladder to heart, goes back to the medullary center, and the efferent activity where leading to intense peripheral vasodilatation, bradycardia. What normally we expect is rise in pressure, vasoconstriction and tachycardia. Rather, what happens is bradycardia and vasodilatation, which causes the peripheral venous pooling causes sudden fall in peripheral venous return, leads to hypercontractile state of the heart. But in reflex, it worsens, leading to bradycardia and fall in peripheral resistance. Other drugs, who are all prone, as I said, elderly people, but particularly people who are taking drugs like diuretics, alpha blocker or ganglion blocker or vasodilators. Again, the point is simple. Drugs that can cause volume depletion, one side. Drugs that can cause vasodilatation. Both can make a person vulnerable for reflex mediated syncope. You can have this two type of thing. One is cardio-inhibitory type where the heart rate becomes slow. Other one is a vasodepressor type where the blood pressure comes slow. This is the femoral artery pressure. You can see the fall in pressure during a tilt table. Same thing cardio-inhibitory where the heart rate suddenly becomes slow, or a mixer. There are three groups. So you can have a bradycardia causing syncope or a hypotension causing syncope, and most commonly both together to some extent. But what is important is these type of syncope can be easily treated. Slight adjustment of the lifestyle, avoiding precipitating drugs, avoiding the environment that can cause. But the problem is we have to identify which group is more vulnerable. For example, unexplained syncope, we go in, a huge group do not have a recurrence. A small group have normal sinus system only. They don't also have a recurrence, or they can be easily treated. But this group who have a bradycardia or a tachycardia, particularly 6% of the patients who are having tachycardia are prone for sudden death. So when we come across syncope, we can easily diagnose it as orthostatic or vasovagal. But if we miss this group, the next news from the patient family is that he is no more. So how to know that? See, if you have a lot of data available when you go to unknown syncope where cardiovascular disease present or absent, if you look, vasovagal is uncommon in this group. Vasovagal syncope is uncommon irrespective of sex, is uncommon in this group when the cardiovascular disease present. So simple rule, if a person comes with syncope, evaluate his heart. If there is a heart disease, do not neglect him, do not ignore that as a simple faint attack, rather investigate him thoroughly so that you may prevent a sudden death. Why? You can see that again, It is a very elegant studies have appeared from Birmingham. What you see is people who had syncope or who do not have syncope or neurally mediated syncope. Both of them excellent prognosis. Actually, there is no difference at all in the survival, whether they have syncope or not syncope. Whereas if it is a cardiac cause, the mortality is very high. So that is the most important thing. So if you come across patient syncope, apart from treating, what is the cause? If it is cardiac, you neglect, you may lose the patient. So you have to see what are the risk factors he has, whether he has heart failure, ventricular arrhythmias, abnormal EKG, age above 45. These are all various risk factors which will predict the risk of sudden death, and the presence of more than 2 risk factors makes the risk quite high. And what are the differential diagnoses? You can think of cardiac causes, as I said, outflow tract obstruction or muscular diseases, abnormal arrhythmias like prolonged QT or AV block or sinus node dysfunction, ventricular arrhythmias. We will see quickly one by one. Before that, how to approach. So now we know the problem is not syncope. Knowing the problem is, if he comes with syncope, are we going to get the syncope married to the heart? Are we going to evaluate him whether he has a cardiac problem or not? How to do that? First, our diagnostic objective will be to distinguish whether it is true syncope or syncope mimics. Number 2 is determine the presence of heart disease. Number 3 is establish a cause of syncope sufficiently to assess the prognosis confidently and initiate effective preventive treatment. This should be the way we approach a syncope patient. So look whether it is really syncope, whether there is an associated heart problem, whether it is a minor one or a major one where we have to intervene very, very aggressively and effectively. What is the initial examination? Even though I said so much, the most important thing is these 2 lines, detailed patient history and physical exam. A proper history and physical exam will give you a right way of diagnosing the patient, treating the patient in more than 45 to 50% of the times. All other tests are later only, like ECG or blood pressure, looking at all these things like Holter monitor, the E1 monitor, the imaging, head up tilt test, everything. But we will see quickly one by one them how they help us today. But what are the questions to be asked clinically? First question, did the patient experience complete loss of consciousness? Because in my practice, when I come across patients referred to me for syncope evaluation, more than 30% of the patients actually did not have syncope. All there was graying spell, or as Vasu said, a disequilibrium state or dizziness, rather than real loss of consciousness. So the question should be clearly asked to the patient. The answer should be very, very certain whether it is a total loss of consciousness, not lying down, I felt dizzy, but still I know my mother is calling. Those things are not syncope. And was it transient with rapid onset? It is not that syncope patient was lying down for 1 hour, brought to the hospital unconscious. There cannot be syncope. He has to recover immediately. Did the patient recover spontaneously and completely and without sequelae? No prodromes or post episode abnormalities. Last is, was there a loss of postural tone? Because there should be a loss of postural tone by an upright person when there is cerebral hypoperfusion. So there should be loss of consciousness, the loss of postural tone. If both are not there, do not make a diagnosis syncope. If both are there, you have made the diagnosis. So in this, if any of these questions the answer is no, it may not be syncope. If more than 2 questions the answer is no, you can be sure that it is not syncope, it is something else involved also. So then initially thorough physical examination, look for heart rate, blood pressure changes, as I said, check the BP both in supine and standing in both upper and lower limb, standing both upper limbs, and cardiovascular exam carefully, look at the ECG changes, look for echo, neurological review, and cortisone massage. Cortisone massage, of course, you have to be careful. We will see that in a second how we should do. Number 1 is you have to massage only for 5 to 10 seconds and not to occlude. Our aim is not to occlude. By occluding carotids, you can cause syncope in many people, particularly if you do both sides, which we never do. And supine and upright posture. You can do even upright posture during a tilt table test. You can do a cortisone massage. What is the end point? Either 3-second bradycardia or asystole, and fall in blood pressure more than 50 millimeters should be there to call this test is positive. And is there a contraindication? Yes, if there is carotid bruit, carotid arterial disease, previous stroke or MI, please don't do the test. Complications are usually neurological, so be very, very careful. If you are in doubt, don't do the test, get for a carotid Doppler or involve the neurologist. Other tests are, as I said, ambulatory ECG, Holter monitoring, event recorder, implantable loop recorder, and the tilt table test and EP study. These are all the tests available. Of course, angiography, MRI, all have a role, and a special situation when there is a need for such tests. To know what it means, all this type of ambulatory ECG means is, to understand this, if you record a ECG, it is recorded for 10 seconds. Just 10 seconds the time it taken for a good ECG to record. So we know the cardiac activity, what happened to that patient for that particular 10 seconds only. If he throws a VF on the 11th second, this won't be recorded on the ECG. Same way, if a person who has had a syncope goes to a clinic, nearby clinic, gets an ECG after half an hour, that need not tell the truth at all. He could have had even a ventricular tachycardia, but at the time of recording, it may not be there. That doesn't mean he never had arrhythmia. So, a resting ECG, if it is normal, doesn't mean you have ruled out cardiac problem. If it is abnormal, yes, it is useful. If it is abnormal, yes, it is useful. But if it is normal, please do not ignore the patient as a non-cardiac cause. Why? We can have longer recording. Holter monitor, now we do even 48 hours or 24 hours. So, if a person comes with recurrent syncope or palpitation, I do a Holter recording for 24 hours or 48 hours. It gives me immense information, provided something happens in that 48 hours. If nothing happens during that 48 hours, again I am in trouble. So, if a syncope is regular almost every day, or if a pseudo syncope every day, I know by doing Holter monitor very, very useful. Next is event recorders. Event recorders are a little longer. Now we have 7 days to 30 days. Event recorders that can be worn by the patient for such a long time, that can give better yield. But the best yield will be implantable recorders. Implantable recorder is where we, like a pacemaker, we implant a recorder in the pericardium. We will go to that briefly, which can record up to 14 months. So, as you record longer and longer time, watch the rhythm longer and longer, you get better yield. That's the important thing. So, again as I said, abnormal ECG is useful, but a normal ECG does not rule out a cardiac pathology. Like for example, here like a loop recorder, you can see a long pause, more than 4 to 5 seconds, or you can have a complete heart block where the P waves are then not conducted. These all can be easily picked up by a Holter monitor, very useful, you can straight away treat the patient. Or you can see like this tachycardias, where you can see the persistent high rate causing a syncope, or rarely these type of things can be picked up during a monitoring where you get a wide chaos rhythm with a pre-existing tachycardia. So, you can make a diagnosis of bradycardia or tachycardia, and you can identify pathways, accessory pathways where you can cure the patient by radiofrequency ablation. So, these are the use of long-term monitoring. And again comes somehow one of these patients like coming to my clinic with one episode of syncope and recurrent dizziness. This is the ECG where we know it looks like not very wide, but really wide cause tachycardia with the AV dissociation. You can see the P waves. We make a ventricular tachycardia. Unfortunate young fellow who turned out to be an arrhythmogenic RV dysplasia. You can see the epsilon wave causing recurrent syncope due to VT. Of course, this is MRI, you can see a dilated right ventricle with the lobulations and thinning of the right ventricle. So, these are the things where you have to be aggressive to think, and this patient finally received an implantable defibrillator, not even a pacemaker, to prevent sudden cardiac death. Next is other common things which we pick up nowadays in our country more and more is Brugada syndrome, an abnormal channelopathy of sodium channel 5 thing, where you can have a various type of thing prone for sudden death. Again, implantable defibrillator is useful. But these type of patients present with syncope, not with sudden death. And what are the other cheaper ones like loop recorder, as I said, the common Holter is having multiple leads to be worn by the patient for 24 hours only, and the lead contact going to be really dicey one. We don't know when the recording will be good, when the recording will be bad. Newer things have come where a simple patch like thing which the patient can wear for 1 week, can even have a shower, he can have a bath, but it will be continuously recorded. Not only that, the recording will be transmitted to a central monitoring station internationally, and the information can be sent to the doctor. So, these are now emerging in our country also. We have been using such things where we make patients who get a recurrent syncope or palpitation, we put the patch, send them home with the recording device. We keep getting information from the central station. If there is any abnormal rhythm, if you come across a VT or anything, we proactively call the patient, start treating him, otherwise we know what's happening. And very important is, if a guy complains of recurrent palpitation and you do 1 week, during that time he had an episode of palpitation where the recording is normal, we know very well. It is mostly a psychogenic one or a functional one. So, a typical report from that comes is like a recording where you see a long pauses, you can get a proper template sent to the physician directly to his email or even to the smartphone. Second is an implantable event recorder, what we use, a small device smaller than a regular pacemaker, which can be safely implanted. It has got a 14-month life, which can continuously record arrhythmias either by patient activator or spontaneously. So, it is a recorder implanted, the accuracy is much higher, but it is a more expensive one. You need to have special programmer to check it, and you can generally we place the record in the pericardial regions, and it continuously records, and the yield will be much higher. Only thing is that it needs an intervention, but the recording will be exemplary. You can have an entire strip of arrhythmia, you can enlarge them, you can do anything as you like, you can start measuring, you have a calipers, everything. It is like having a non-invasive or a partially invasive EP study to these patients. And various arrhythmias which has been picked up by an ILR like a ventricular tachycardia or a supraventricular arrhythmia or even a bradycardia. Coming to next one, very important test, not for cardiac. When the cardiac is ruled out, head up tilt test, which is used in the diagnosis of vasovagal syncope, where the patient is placed at 70 to 80 degree angle for a period of 45 to 60 minutes and looking for symptoms of bradycardia, hypertension, and we try to augment them with giving isopropyl. This is how a patient will appear in the thing, well supported by the couch with wearable belts and continuously monitor arterial pressure. You can see any fall in arterial pressure can be recorded or bradycardia. This test is very useful in people who have recurrent syncope but no cardiac cause. You do this, and if it is positive, the chance of it being a vasovagal is very high. Then comes an echocardiogram. We do come across some of the patients who present to us with syncope like an atrial myxoma. You can see the large myxoma occluding the mitral orifice intermittently can cause syncope. This is one type of organic thing which where you can give a cure by operating or kill the patient by missing it, or mitral stenosis where the syncope is uncommon but can occur, uncommon compared to myxomas, or you can have other common condition we come across is aortic stenosis with a very high gradient. These patients are prone for recurrent syncope. So, valvular heart disease, and there is another patient who present to us with syncope, but what he had is a large pericardial effusion. Large pericardial effusion almost compressing the right ventricle totally like a slit like right ventricle. So, his cardiac output is so low leading to loss of consciousness. With the proper pericardial centrosis, they recovered. And last I come where we do the invasive work, putting into catheters inside the heart, looking at the cardiac rhythm, try to induce arrhythmia in a person who is prone for arrhythmia by history and by physical examination, but we have not concluded the diagnosis, where you record ECG, intracardiac ECGs by keeping catheters close to the ACA node or AV node or in the right ventricle. Like this, you can keep an electrode in the coronary sinus or the right atrium, is bundle, RV. So, you record a ECG inside, try to induce, pace the heart, bring the arrhythmia. That will be a thing. I will show for example how it look like a typical patient where we have a catheter in the coronary sinus, one in the east position, one in the CS os position, or other one is the left atrium. So, you can keep catheters inside, try to provoke the arrhythmia. For example, a typical case recently we did, patient in sinus rhythm, this particular 8 beats are what I am pacing. You can see that pacing spikes, and I am pacing and then give 3 premature stimuli to induce ventricular tachycardia. This person had a recurrent VT, so we could induce a ventricular tachycardia. So, we know the diagnosis and which helps us to treat. So, currently to manage syncope, the rule is please diagnose confirmed syncope. If syncope, please rule out coronary artery, cardiac disease. If cardiac disease is ruled out, the prognosis is going to be excellent. If cardiac disease is involve the cardiac team to plan so that we can prevent death. So, again to initial evaluation, see whether it is syncope or not syncope. If a certain diagnosis is treat,